Hello everyone, in this video I am going to discuss how to approach an acutely ill patient in emergency department or ward. You cannot just do the normal history taking things like presenting complaint, history presenting illness, past illness on and all that. It will take a lot of time. So your aim should be at determining the causing the life-threatening condition and immediately manage it. So we should do it with ABCD approach. When we should do ABCD approach, any patient in coming in acutely in condition, okay, or any patient coming in ambulance, an ambulance, that technician addressing you that the patient has decreased BP or increased heart rate, etc. The patient is in ward and you are in on doctor's on-call room and sister asks you to see the patient who has just collapsed in ward. In all the cases you should approach ABCD approach. So basically we trying to do 3 cases in this video. Actually case 1 in this video and other 2 cases in next one. So case number 1 is 19-year-old boy Dinesh came to the emergency department. He was stung by bee. He was playing in playground and he naughtily threw a petal to a beehive and he was kissed by thousands of bees. Okay, and he was taken to the hospital by his friends, and on arrival he said that he felt dizzy and weak. Case number 2 is in short. Patient admitted for TIA evaluation, transient ischemic evaluation, and the patient suddenly collapsed in the ward and sister asked you to see the patient. Case number 3, Mohesh Babu, 70-year-old, came with flank pain, dizziness with weak pulses in both side femoral. So these cases will cover mostly the ABC part. Let's start with ABCD. As you know, A stands for airway. Always try to ask the patient about the complaints, about his complaints, not the patient relatives. And if the patient can talk, then the airway is secure. Then he can go to breathing part. But if patient cannot talk, then he should surely look for airway obstruction. And how should we look for airway obstruction? You can look at the airflow at the mouth level. Okay, and you can observe any throat or tongue swelling part. That's number 2. Number 3, you can hear in sound, gargling sound or snoring sound or choking sound or stridor sound, like that. And also you can look for paradoxical breathing that can give you a condition like air obstruction, etc. If you suspect air obstruction, first secure it, then next to B. Or if the patient can talk, go to B straight away. And breathing part, you should look the 4 things. One is SpO2, and always mention in room air or oxygen at what level, what liter per minute. Tracheal deviation. Next, breathing rate, depth and symmetricity. And 4th, percussion and auscultate chest. Next is C for circulation. Here you should check the color and temperature of the hands, capillary refill time, pulse rate, rhythm volume mainly, BP and auscultate heart. And D stand for disability, capillary blood glucose, GCS level, any drugs or allergies, or dilated pupil. That means pupil examination. I just did the D part to sign this with this. And then exposure with dignity, or injuries part. Exposure for looking for any bleeding or injury in case of RTA, rashes, medical bracelet or any dark patches. Next, come to the case 1. 19-year-old boy came to the ED stung by bee, dizzy and weakness. So always suspect in these cases. Anaphylaxis is always suspect, and acute condition always anaphylaxis, and is always occur within minutes to hours. Let's say 5 minutes to 1 hour. It never has that you was stung by yesterday and now comes to patient and today in ED and complaining of anaphylaxis. You diagnose anaphylaxis. That's wrong. patient was stung by bee at least within an hour or two. And when should we diagnose anaphylaxis? One is skin feature or mucosal symptom along with respiratory symptom or hypotension or any organ damage, or you can diagnose any of the two of skin symptom, respiratory symptom, hypertension or persistent GI symptom such as emesis or abdominal pain, or third is decreased blood pressure after exposure to allergen such as he has taken food in any restaurants for say or any nuts etc. In adults we say SBP less than 90 millimeter Hg and more than 30% decrease from baseline, and infant in children there is difference. This chart is taken from Washington manual. So in nutshell, a patient should have skin symptom with respiratory, CVS and GI. Skin symptom with any of those will see the diagnosis of anaphylaxis. There is test serum tip test but not available in all center. Peak level at 1 hour. You can order it, but usually the diagnosis of anaphylaxis based on physical and clinical examination. That's it. So now how should we treat it? First and foremost, you should lie the patient in recumbent position, never in sitting or standing, and then you should secure the airway. As I saying ABCD approach, you should secure the airway. You may find there is tongue swelling or not maybe, but you should always start with 100% oxygen. You should always be ready with airway securing device, maybe 6 or advanced airway securing device. The tongue swelling may decrease by administration of adrenaline, but it may not. So you should always be ready. Many centers prefer endotracheal intubation when the patient comes. They do not wait to see the adrenal effect. But if the tongue swelling develops, you cannot do the intubation. You have to do cricothyroidotomy or tracheotomy. It is preferred over tracheotomy. And the first and foremost drug you should always give is adrenaline. Dose is 0.3 to 0.5 ml IM in lateral side of leg, thigh. Always give. Never hesitate to give. If patient came with anaphylaxis. In India, ambulance, there is nobody gives adrenaline to patient. You should first foremost give adrenaline in ED. And two more things, while giving adrenaline, patient should be in recumbent position, in lying position, or you may see empty ventricle syndrome in patient sitting position if you give adrenaline. And after 10 to 15 minutes, if the patient does not improve, you should repeat the dose, same dose. If after 20 minutes, even after 20 minutes, if patient does not improve, there is a poor prognosis. You should call the expert for IV administration of adrenaline. That 0.3 to 0.5 ml, that was 0.3 to 0.5 mg in 1:1000 dilution. But IV dose is 1:10,000 or 1 lakh dilution. So IV should be given only by experts and under ECG monitoring. Always remember ECG monitoring. That's it. And one more thing, there is no absolute contraindication of adrenaline. Always remember that. And volume, you should always give 500 to 1000 ml bolus dose. And as you give adrenaline, it may take the hypertension part, but if does not treat the hypertension part, you should start with IV vasopressor. Here also IV adrenaline is preferred with expert opinion. IV dopamine can be given in deep set. That's it. Now after securing the cardiovascular stability, there is airway, oxygen, intubation or cricothyroidotomy in extreme cases, adrenaline 0.3 to 0.5 ml, IM lateral thigh, volume securing IV, then 500 to 100,000 ml bolus, and then recheck. Always observe the patient or measure the vitals. You can titrate the volume, IV bolus, IV fluid part according to BP or urine output and or urine output. That's it. After controlling the airway, giving adrenaline and securing IV and giving bolus, you should look after other things such as anaphylaxis histamine related thing. You should give always H1 blocker with H2 blocker. It is said that only H1 blocker give effect, but it is less than H1 plus H2 blocker. That means H1 plus H2 blocker give more effect than H1 blocker only. So you should give H1 blocker chlorpheniramine 10 to 20 mg IV slow, or diphenhydramine as 25 to 50 mg IM IV, or parallel patient can take orally. This mainly takes care of the skin symptom, urticaria part. You can repeat diphenhydramine every 6 hours if needed. Along with this, you should give H2 blocker cimetidine 300 mg per oral every 6 hours, 4 times daily every 6 hours for 2 to 5 days. If you discharge a patient, you can change the cimetidine part to second generation antihistaminic like loratadine, desloratadine, etc. Now corticosteroid, glucocorticoid. You should give always hydrocortisone. Dose would be 200 mg IV. This does not take care of the cardiovascular stability, but is surely decrease the severity of the condition. And if the patient is beta blocker, such as let's say migraine prophylaxis or hypertension, you should always give glucagon. Glucagon when refractory to adrenaline, when the bronchospasm or hypertension is refractory to adrenaline, glucagon does the magic. Dose is 1 to 2 mg IV stat, then followed by 5 to 15 microgram per minute, titrated to clinical response. That's it. Even resistant bronchospasm can respond to beta adrenergic agonist inhaled 0.5 ml albuterol with 2.5 ml NS in nebulized form will treat the bronchospasm. That's it. Now let's say patient have a minor symptom, only skin symptom. Then what should you do? Skin symptom, no cardiovascular, no respiratory, no GIT. Then what should you do? You should only do the antihistaminic part. But the old edition says you can also give the adrenaline by subcutaneous or IM route. In some book it is written you can only should observe the patient with conservative management. How long you should observe the patient? For 6 to 8 hours in case of minimum symptom. That means skin symptoms only. Why should be 6 to 8 hours? Because there may be biphasic response. In many cases, the manifestation of anaphylaxis may come up at 6 to 8 hours in a biphasic response. Patient with cardiovascular instability, you should observe for minimum 10 hours. In some cases, some physician prefer 24 hours observation period. And in some cases, for a patient with history of MI, or patient is intubated, or patient is having IV infusion of vasopressor, you cannot discharge quickly. So the patient may stay longer in hospital in those cases. Now, while discharge, what should you do? Which medication you should prescribe? Prescribe prednisolone 50 mg per day per oral for 3 days, loratadine 10 mg OD for 10 days, cimetidine 300 mg for 3 days, all 3 days. You can also give famotidine, and you should offer referral to patient after discharge to any allergist to see whether patient is allergic to any specific substance, or offer the patient to have any carry EpiPen. So that's it. In a nutshell, when you see a acutely ill patient within a hour presenting after exposure to allergen, maybe bleeding, maybe food, maybe any drug, you should always suspect anaphylaxis. First and foremost part should be position, lying position, airway, adrenaline, volume, and then you should do the 4 things: H1 plus H2 blocker, glucocorticoid, glucagon, inhaled. And not just giving drug, you should also observe the vitals of the patient, record the vitals of the patient, so that you do not want the patient to deteriorate. And it is said that in 70% of cases, patient may need second dose of adrenaline after 10 to 15 minutes, same dose. Even if after second dose, if patient does not improve, always seek expert opinion for IV dose, IV infusion. That's it. Admission I have discussed, discharge and referral. So see you in next video with case number 2.